Thank you. Welcome to the special meeting of Adult and Wellbeing Health Overview and Scrutiny, taking place today, Friday the 25th of February 2022. I'm Councillor Patricia Jopling, Chair of the committee. To my right is Stephen Gwillam, and to my left is Rochelle Charlton-Lane, who is the Vice Chair, which is, where am I? I would like to also extend a warm welcome to our partners from the NHS. Where am I? Sorry about this. Rochelle, you've thrown me out. Yeah,
that one.
Right, yeah.
I know.
Yeah. To my left is Amanda. No, she's not. Where's Amanda?
Not here, Chair. Sorry. She's not here, Chair. Apologies. Just go over.
She's not here today, is she? No. Right. I'm really sorry about this. I would also like to welcome officers from the Council and our NHS partners who are presenting to the committee this morning, and any members of the public, media, or who are either in attendance or watching our broadcast on YouTube. Moving on to the agenda. Item 1, apologies for absence. Kirsty.
Councillors Andrews, Higgins, Holmes, Martin and Stubbs.
Substitute members?
Councillor Coslett for Holmes.
Right. Declarations of interest. Any member of the committee have a declaration of interest? No? Item 4. Items from co-opted members. No? Okay. Stephen, questions from members of the public. Stephen now will go through.
Thank you, Chair. Yeah, we have at item 5 on today's agenda a question that's been received from Mr. Mike Cunningham regarding County Durham and Darlington NHS Foundation Trust's do not attempt cardiopulmonary resuscitation policy towards those patients whose lives are deemed best served by surgical and medical staffs. The question's been placed on the overhead for members' information, Chair, and the process will be that Mr. Cunningham will ask his question. So hand over to you, Chair.
Yeah. Before inviting Mr. Cunningham to ask his question, I would like to advise everyone on the process to be followed. Mr. Cunningham will ask this question, and I will invite representatives of Durham-Darlington NHS Foundation Trust to respond to the question. Once the response has been given, there will be no debate on the matter, and the response will be included in the minutes of this meeting. Can I invite Mr. Cunningham to ask his question?
Good morning, Madam Chairman. Can you hear me? Can you hear me? Madam Chairman, it is my assertion that there has been a disconnect between the County Durham and Darlington NHS Trust and its University Hospital of North Durham medical and surgical teams, and the patients, family members and legal trustees of those patients in a specific area of the do not attempt cardiopulmonary resuscitation (DNACPR) policy towards those patients whose lives are deemed best served by the surgical and medical staff's decisions to apply those same DNACPR notices without adequate and informed discussion of that notice with patients and or concerned family members or legal trustees. I searched through the recently published meeting minutes of the Adults, Wellbeing and Health Overview and Scrutiny Committee for any sign that a shortcoming all in the University Hospital of North Durham structure in medical patient end-of-life conversations was being researched or corrected, but found nothing. The Court of Appeal's ruling on Tuesday, the 17th of June 2014 stated, "You have the right to be involved in discussions and decisions about your health and care including your end-of-life care, and to be given information to enable you to do this. Where appropriate, this right includes your family and carers. I only learned of the existence of a DNA CPR notice regarding the decision not to resuscitate my beloved wife when I read a copy of the hospital report which was sent to the coroner regarding my late wife's admission, surgery and death in the hospital in early May last year. Given that apologies and expressions of sincere condolence were eventually stated by the hospital, as well as promises made to me that staff would be reminded of the importance of empathy and sympathy by January 22nd, 2022, when discussing proposed DNA CPR notifications, has the Council's Adults, Wellbeing and Health Scrutiny Committee been recently made aware of any changes to both best practice as well as abiding with published changes to the law in the specific area of advice and discussions of DNA CPR notifications to patients, family members and trustees? I thank you, Madam Chairman.
Thank you very much, Mr Cunningham, and please accept the committee's condolences for your loss. Did you say you wanted to come in? Yeah. Stephen?
Chair, just for clarification, the question posed is whether the Council's Adult Wellbeing and Health Scrutiny Committee have been made aware of any changes to best practice. As members of the committee will be aware, we haven't discussed this issue in any element of detail, so in order to respond to that particular element of the question, we have invited representatives of County Durham and Darlington Foundation Trust to set out the Trust's policy and practice in terms of the DNR CPR, and that will be the subject of the presentation to members that that's going to be given this morning. Thank you, Chair.
Thank you, Stephen. I would now like to invite Carol Langridge, Deputy Chief Executive of Durham and Darlington Foundation Trust, and David Oxendine, Palliative Care Consultant, to respond.
Thank you, Chairman. Dr. Oxendine is going to deliver the presentation today.
All right,
Thank
okay.
you.
Thank you.
Thank you. I don't come here very often, so I'm not quite clear on the formalities. So thank you for asking me here. Thank you. Mr. Cunningham, I'm very sorry for your loss, for your wife's death, and for the things that the Trust didn't do right, that individuals didn't do right during that process. So I know that we've acknowledged that already, but I'd just like to do that again before I start. So my name's David Oxendine. I'm one of the palliative care consultants in the Trust. I have worked in County Durham for 9 or 10 years. I've been a doctor for a very long time, it feels. And I'd just like to take you through the basis on which and the reason why we have the policy that we have and then we have the practice that we have, because I think it's still quite poorly understood. We've referred already to the Court of Appeal judgment, and that was very helpful. It also said that this was a complex area, and I think sometimes people feel that a resuscitation decision is an easy decision. It feels to me, as I speak to people, that quite often patients and families think, well, if I want to be resuscitated, I'll be resuscitated, and if I don't want to be resuscitated, then I don't want to be resuscitated, and that's the end of the discussion. And it is more complex than that. I'm going to try to explain just a little bit of why there is that complexity. I've been involved even this week in several discussions which have taken a number of members of staff and family and patient quite a length of time, So I'd like to assure you that despite the fact that we do get it wrong, and we obviously have done, that we do take this seriously, and that we spend time trying to get it right. So this is the challenge, is that in the 1950s CPR was invented, and it was invented to resuscitate young people who had drowned. So the first paper ever about resuscitation was in Chicago, and it was people who drowned in the lake and got taken out, and the success rate was about 70%. So there's this idea right from the start that CPR is something that works. And then you have people like Christian Eriksen, who are clearly extremely fit and well, and their heart stops, and his heart stopped, and people applied cardiopulmonary resuscitation, and he got better again, and now he's back playing football. And people think, well, that sounds good. You know, that's a good intervention. And the difficulty is that as we get older, or as we get iller, then the chances of resuscitation become far less, to a point where, for many people, it doesn't work. And where something doesn't work, it doesn't make sense for us to be doing that. And that's the basis of some of the policy that I'll come on to. So one of the doctors have got very good, and medicine has got very good over the last 100 years. 100 years ago, if you could do something to make someone better, then you did it. And generally people had one illness, and doctors actually weren't very good at trying to get that illness better, but they would do it. We've now got to a stage where we're actually quite good at keeping people alive, which is a great thing, which is why we have so many people who are 80 and 90 years old. I don't think it's just that. I think the council has had something to do with it as well. So I think all of the public health measures have helped, but generally doctors keep people alive much better. But there comes a point when people have 4 or 5 different illnesses and things don't work that would have worked had they been young and fit. So I just want to show you this next. Now, I don't like the word futility, but it was in the paper title of this paper, and so I've used it. I would rather say that things don't work. So this is all of the resuscitation attempts in a hospital in a year. And there's a thing called a clinical frailty score. Now, the blue are the people who have survived that resuscitation attempt. So they've been in hospital, they've had their heart has stopped, the team has come along and applied chest compressions and electric shocks, and they have got better. The red are the people who haven't. When I'm in hospital, I'd really quite like to know whether I'm going to be in that red box or in that blue box, because CPR is a really deeply unpleasant thing to have done to you, and if it's not going to work, then most people don't want that done. So, what does that look like? So what this paper suggests is that if someone can't do their heavy household work themselves, if they need their grandson to come and do their shopping, then that's the level at which, in that study, nobody who was that frail, and that's not very frail, nobody who was that frail survived a resuscitation attempt. And then I want to make this point fairly clearly, because I think it's important to realize why we're just not going along and speaking to people and saying, do you want to be resuscitated? Does that make sense? Okay. So, although your phones are switched on silent, if you want to, then there is and you have a search engine, then please search Deciding Right Northeast, and you will find the whole basis on which we make decisions in hospitals, not just in County Durham, but across the Northeast. So there's a Northeast initiative, some very bright people, together with lots of doctors, nurses, patients, patient advocates, got together and said, how are we going to do this? And you will find all of this is all publicly available information. And it's the basis on which we make decisions. There's also an app, if you like apps, which will guide us through the process of decision making. And therefore we have forms, and this is a DNA CPR form, which are regional forms. Now, I'm not going to show you all the detail of those, and I'm just showing you the picture rather than the detail. But one of the fundamental principles behind this is that there are two kinds of decision making when it comes to resuscitation. So when we come to a decision about cardiopulmonary resuscitation, the first thing, and this is what we teach all of the doctors, all of the nurses who are involved in these discussions, the first thing we ask ourselves is, do we think there's any chance that that a resuscitation attempt would work? Now, if the answer to that is yes, it might, then the discussion is one of a discussion with the patient or with the family about whether that person would want a resuscitation attempt. So that's a, do you want to be resuscitated? And that seems reasonable. And a lot of people coming into hospital are in this situation where the answer to that from the medical team is no, we can see no way, no realistic chance of this working, then that's not a choice discussion. When I speak to the medical students, I say, so if I said to you all, do you want to go on holiday to Tenerife next week? And you all say yes, and they do nod generally. They say yes, we'd like to do that. And then I say, well, you can't. Then that wouldn't be a reasonable thing to do, would it? That wouldn't be fair or kind. Do you want to go out to dinner tonight? Yes, I do. Well, we're not going. No, that's not okay. So that we don't do that to patients either. We don't do that to families. So if something won't work, then that is a breaking bad news discussion. And we have a very clear kind of way of teaching and doing that. But it's a discussion where we are sharing the bad news that this thing won't work, rather than giving someone a choice. So for all of those people who, and all of us at some level, either ourselves or with relatives are going to be involved in those, that's the basis on which we should be having those discussions. And we don't always get that right, and we have a lot of staff, a lot of doctors in training coming through our trust, a lot of doctors in our trust, and so we will get that wrong sometimes, and we won't communicate that as clearly as we ought to. But that is the policy, that is the intent, that where something won't work, we'll be as clear about that as possible. We'll communicate that to families. Now, if they say, I don't believe you, then that's valid, because I'm only expressing an opinion. So where someone doesn't believe me when I say this thing won't work, then generally that's when I get involved, and we will have further discussions about that and work out some way of dealing with that. But where something won't work, we don't offer that as a choice, and we don't impose that full sense of responsibility and distress on patients or families who might think that they're being put in a position of denying their mother an intervention, That's not what we're doing. And I hope I've said that 15 times now. I hope I've said that clearly enough, and that makes sense. So this form generally sets that out. The top boxes are statements where we say we're not going to do a resuscitation attempt because it won't work, and then we put in why it won't work. And then there's other bits further down the form to say it might work, but the patient doesn't want it, because there are people who don't want to have a resuscitation attempt, and we would always respect that. And there's other bits which are relevant to patients who lack capacity, who can't speak for themselves. And I have to make it very clear that when someone lacks capacity, we would always, and our policy is always to discuss that with family members. And I'm aware that that doesn't always happen, and that we make mistakes, and that we go back and review those. But that's what we aim to do. On the back of the form, and you can access this online, so it's not a secret thing. And if my brain worked well enough, I'd have brought some for you all this morning, but I didn't because I forget stuff. On the back of it, it sets out exactly what I've told you. The top box says, might it work? If it will work, then discuss it with the patients. If it won't work, communicate that sensitively to the patient and go through the rest of the process. Okay. So we have regional framework, we have regional guidance, and I've shown you some of the documentation behind that. Most doctors will get that education as part of their training, and we're not always involved in all aspects of doctor training, so we don't have control over that. But we do try to support and develop junior doctors' understanding of these issues as they come through our hospitals. For the nurses, and we have some advanced nurse practitioners and nurse specialists who are involved in these discussions, and they're very good at it. We have a training program for them and a competency assessment for them. When things go wrong, and things do go wrong, then we will look at that. We will deal with that either on an individual level, if that's an individual thing, or if there's a general piece of learning. And last year we had some general learning around people with learning disability, and some doctors had got into the way of putting, as well as every other reason why something wouldn't work on that form, they also wrote learning disability, and that caused a lot of distress, because I think it was misunderstood. And I think it understandably misunderstood that we were choosing not to resuscitate people because they had learning disability. That wasn't the case. I looked at all of the cases, and it was very clear that in all of those cases they were the right decisions, because they were people where the resuscitation attempt would not work, and therefore it was a correct decision. But we had not written it and communicated it properly, and so we've made sure that, as far as we can, that we don't write learning disability on resuscitation forms. We write the reason why the intervention won't work. It's kind of logical, but sometimes people get distracted. More recently, our junior doctors seem to have done some diagnostic dumping. So instead of writing a clear reason why the resuscitation attempt won't work, they write every diagnosis that the patient has, and I'm trying to discourage that. It's not a terrible thing, but it's not a good thing. It's not a clear thing. So we do look at incidents, try to learn from them. We do look at complaints, and very much try to learn from those. And we also, through our acute intervention team, and our cardiac arrest prevention team look at the documentation and audit that. And we also look at every CPR attempt. Every time we attempt CPR in the hospital, then we will review that and see if there's anything to learn from that. Okay, so thank you for listening, and thank you for allowing me to come and just talk about something that I think is really very important. What are the key things I want to communicate? We still have and maybe it's Holby City, or maybe it's just that doctors tell you that we are better than we are, but we still have an expectation that CPR works much better than it actually does. And I hope I've shown you some of the concrete evidence to explain why that isn't the case. These discussions can be distressing. They aren't always, and for many people that I speak to, they go, no, I don't want that actually, and I'm trying to say this won't work, and they're going, well, I wouldn't want it even if it did. So for some people it's fine, but for some it is very distressing and takes a lot of work, and part of the work of the palliative care service is to support those discussions. And it can be difficult to communicate. I think that we have a range of staff in the trust, and some people find that harder than others, and we sometimes get it wrong, and I hope, and our intention is, when we get it wrong, to acknowledge that clearly. But I hope you've seen, and I want to reassure you that we have a high level of commitment to making improvements, and that I feel that our policy and our practice is as good as it possibly can be, and where there are opportunities to improve that, then we'll do so. But we are good at this, and we will always try and find ways to make to get better. Thank you very much. I'd love to stop and chat, but I think you've going to move on, so I'm going to say goodbye just now.
David, can I thank you very much for coming and giving that presentation, because it is a really difficult subject, and I'm very grateful. Thank you.
Chair, just by way of process, just to confirm that the response will be fully recorded in the minutes of the meeting, and a copy of those minutes will be sent to Mr. Cunningham, who submitted his question. Thank you.
Thank you, Stephen. Mr. Cunningham, you're more than welcome to stay for the rest of the committee if you'd like. Thank you. Item 6, we're now going to discuss the 111 service and the performance. Members will find the report from page 5 to 24 of the pack. I will now pass over to Stephen, Principal Officer, to introduce the report.
Thank you, Chair. Yes, this special meeting has been called this morning to consider the 111 service and 99 service that are both currently operated by North East Ambulance Service NHS Foundation Trust. The basis of this morning's item is that the 111 service, as members will recall, has been referenced in a number of occasions where issues have been considered by the committee in terms of the ability to access services. We had a presentation back in November on access to face-to-face GP appointments. We also had a presentation on access to NHS dentistry services. During both of those presentations, the use of 111 service to access both of those were referenced, and it's also been referenced in some of the discussions that the committee has had in respect of accessing mental health services too. So in order to give North East Ambulance Service the opportunity to explain fully the 999 and 111 service, and also the processes involved in that service and the issues around capacity and how the service works and system pressures. That's the reason why we've included this item on this morning's agenda, and representatives of North East Ambulance Service are in attendance to provide members with a presentation that sets out a lot of the information that members requested during consideration of those previous items, Chair. So I'll stop there, Chair.
Who's introducing?
I'm not sure who's introducing the
Exactly.
presentation. We do have representatives. We have
It changed.
we have Paul Liversidge, Chief Operating Officer, Mark Hunter, the 111 Section Manager, who I believe is just giving the presentation. Geraldine Hope, who's the Assistant Contact Centre Manager, and Mark Cotton, who's the Assistant Director of Communications and Engagement. Thanks, Chair.
Right. Thanks, Stephen.
Good morning, everyone. Little introduction first of all from myself. So my name is Mark Hunter. I'm a section manager in the Emergency Operations Centre at North East Ambulance Service. I've worked at Nhs now for 12 years. The first 3 years of that time was spent actually taking 111 and 999 calls, as well as being a trainer during that time. So I've got a good idea of what I'm talking about today. So my job for the last 6 or 7 years has been to help operationally manage the Emergency Operations Centre, specifically call handling, and that includes 111, 999 and our dental service. So today I'm just going to run through a few elements to answer some of the questions that have been raised. I'm going to start by talking about the current services that are delivered by North East Ambulance Service, just to give you a flavour of what we do. And then I'm going to talk a little bit about Nhs Pathways and how that works in terms of how calls are triaged. Then I'm going to talk a little bit about how 111 and 999 integrate with other healthcare services across the North East. And then I'm going to get to the crux of what we've been called today to discuss, and that's a little bit about our demand in 2021. And then I'm going to move on to talk about our demand this year and how we've turned a corner. And then a little bit about call outcome analysis as well. And at the end as well, I'm going to give opportunity for questions. So to begin with, a little bit about the current services delivered by North East Ambulance Service. So rather obviously, first and foremost, we deliver the 999 service for the North East of England. So this covers the call answer service, which is supported by a number of clinicians working within our Emergency Operations Centre. We also manage the dispatch service to dispatch the ambulances to get to patients across the North East. And we have over 500 paramedics working on the ambulance network, working alongside emergency care assistants and ambulance technicians, and those are operating in 550 vehicles across the North East. In addition to that, we have the 111 service, which we have delivered for 13 years now. 111 has been well established in the North East. We were one of the first to deliver the service to Durham and Darlington between the years of 2010 and 2013, before the service went national. And since then, we've delivered it for the last 10 years. More recently, 2017, we developed our clinical assessment service, which supports our 999 and 111 service, but also supports the wider healthcare economy in the North East as well. And within our clinical assessment service, locally referred to as our CAS, we have employed GPs, a range of healthcare professionals. We have GPs, advanced practitioners, paramedics, nurses, pharmacists and dental clinicians, all working to support our 999 and 111 services. OCASA also manages referrals from those patients who now can complete an online triage via NHS 111 online. Fourth, Nhs also provides pre-planned non-emergency transport, that's our PTS service, patient transport service, for those patients that are travelling to a treatment centre to get that treatment. So an example of that could be a patient going for dialysis, for example. And our most recent service launch is our dental clinical assessment service. And this is a mainly out-of-hours service for the patients in North Eastern Cumbria where, as the title suggests, we deliver an out-of-hours dental service. So we work in partnership with a local dental provider called Dentcall, which are based in Durham. And Dentcall has a team of around 40 dentists and dental nurses who work on that service delivery in conjunction with Nhs. So that's a little bit about who we are. And I'm going to move on now to talk a little bit about how we deliver 999 and 111 and the algorithm that we use to do that. And that's called Nhs Pathways. So Nhs Pathways, for those of you who don't know what that is, in very simple terms, it's a clinical decision support system. It contains hundreds of clinical pathways, and which is primarily used by non-clinicians, but not always. We do have some clinicians that will use pathways as a guide and a support in their line of work. So quite simply, when patients call 111, they're asked a series of questions. Some of those questions might not always seem relevant to the patient or the caller. However, they're all very important to ensure a safe and thorough assessment. Indeed, a common criticism of 111 over the years is around that very point. Patients sometimes feel that they are asked a lot of what they seem or feel are irrelevant questions. However, as I've said, all of those questions are important to rule out potential diagnoses. And on that point, Pathways doesn't set out to diagnose at the end of a triage. Absolutely not. It's not a diagnosing tool, but it works on the basis of ruling out diagnoses. So when a point is reached where Pathways cannot rule a condition out, the triage will end and a disposition will present for the health advisor or the call handler. And what that disposition will contain is a clinical skill set and a time frame that directs the patient to the next level of care. So a straightforward example of that might be at the end of a triage, the health advisor will advise the patient that they need to be referred to an emergency treatment centre within 1 hour. Or they may well need to be seen by a local service within 6 hours, typically a primary care service. So that's your bog standard GP referrals. It's important to note as well, Pathways works with the directory of services to return appropriate services based on the patient's symptoms and the questions that they've answered positively to during the triage. And what the Directory of Services is essentially a database of every healthcare provider and the service within the whole of the UK. And this contains thousands and thousands of entries, as we have thousands and thousands of services. On each DOS entry, the service will stipulate when it's open, what patient age group it can take, the patient age group it accepts, and which clinical outcomes it can manage. At the end of the triage, Pathways takes the information the health advisor has gathered throughout the call, and then it essentially talks to the DOS to ask what services are appropriate for that particular patient and their presenting symptoms. Then it will share the services on screen for the health advisor to offer to the patient or to the caller, and all of that is done in a matter of seconds, the wonders of technology. So a little bit more about Pathways, just to give some assurance about Pathways as a clinical resource and tool that we use. Pathways was developed. Keep forgetting to move that forward. Pathways was developed and continues to be maintained by a group of NHS clinical professionals, some at a very, very senior level. Pathways is under constant review to tweak and enhance and improve its effectiveness. Typically, there will be 2 pathways updates each year. Where new pathways are added, questions will be tweaked or removed, or care advice can be updated or changed. And because of this, training is delivered to our health advisors working within our service to compensate for that and to make sure they're always refreshed and are delivering the correct advice to our patients all of the time. That training can typically take a half day, and sometimes that's classroom based, or sometimes that's online, virtual, etc. A clear example of how Pathways always is continuing to improve, a release in 2019 contained improvements that had been estimated to generate 300,000 less ambulances from 111 throughout the UK. And some additional, just before I move off the topic of Pathways, a little bit more information on Pathways and what it does. I'll not repeat what's on screen. That reference to 509,000 calls triaged in 999 using NHS Pathways in 2021, that relates to the calls that Nhs have taken in that year. So we use NHS Pathways for both 111 and 999, so regardless of which number the patient calls on, they are triaged in exactly the same way. And within Nhs, we are one of the few organisations that deliver the 111 and 999 service that utilises dual-trained health advisors. And as the name suggests, that obviously means that those health advisors are trained to handle 111 and 999 calls. And from a business perspective, that's very advantageous for us because it gives us the ability to dynamically manage and flex staff between both the 111 and 999 services. So in simple terms, when 111 is busier, we'll flex the staff and have more staff taking 111 calls, and vice versa on 999. And talking of health advisors and when they deliver this care for patients, in order to do this, it's important for me to mention the training that goes on before they are fit to take and triage these calls. Each health advisor completes an intensive 4-week full-time training course on Pathways. They sit assessments and complete live audits with a trainer, and they must achieve a minimum pass score in order to be signed out of training and start actually taking live calls. And once live, every health advisor is assigned a team leader who will then continue to coach that member of staff. And in addition to that, with the learning, the coaching, it never stops. Each health advisor has 5 random calls pulled out from an external audit team. And all of those calls are audited for quality and safety. And if there's any feedback for the health advisor, that will be delivered by their team leader. And also day to day, I think this was mentioned in the briefing about the support available for health advisors. It's important to mention this point. During a live call, health advisors can access a number of different support mechanisms. They have access via a hotline to a senior health advisor for any process queries or any operational queries that they have. And they also have access to a clinician for any clinical queries. So we recognise that whilst the training is intensive, that they're given initially on Pathways, there will be things that crop up from time to time on 999 and 111 calls that the health advisor will recognise is outside of their expertise. And for that reason, they can call on a clinician via a quick telephone call to get extra help. There's always a clinician in the room at the end of a phone. In fact, there's usually 5, 6, 7, 8 in the room to be called on at any time. So I just want to talk a little bit about 111 and 999 and how we integrate with other services, not just in the North East, but across the country now. 111 has developed so much in the last 10 years, and I've been lucky enough to enjoy that journey. In the early days, when I first started Nhs, it was largely, 111 was largely a signposting service. However, I'm pleased to say these days, with all the technological advancements, 111 and 999 can integrate seamlessly, electronically, with most other healthcare services throughout the North East and the rest of the country. So just going through this list in a little bit more detail. 111 can integrate with GP practices, so a patient can call at 111, and at the end of that, if the patient needs to be seen by their own GP practice, the health advisor within 111 can book a face-to-face or indeed a telephone appointment in the patient's own GP practice. Additionally, they can send the details of that full triage direct to the GP practice, and all that happens in a matter of seconds. The next bullet point, extended and enhanced GP services. So this is something, an advancement that's been around for the last 5 years or so. And again, much like GP practices, our health advisors can book a face-to-face or a telephone appointment in one of the many GP extended hours services that operate typically Monday to Friday between 4 p.m. and 8 p.m. and on Saturdays and Sundays as well. We can also book patients directly into dental hubs, and there's 17 now dental hubs across the region. That's a strategy that's unique to the North East. Just to summarise that and flesh that out a little bit more, we offer 466 urgent dental appointments every single week in these 17 dental hubs. And the fourth point, we can also, this is probably one of the most recent developments, we can also book an arrival time into all emergency departments in the region. So quite simply what that is, once a patient is triaged within 111 or 999, at the end of that triage, if the patient doesn't need an ambulance, but they do need to be seen in an emergency department, the health advisor can advise the patient that they need to attend the emergency department within a set time frame. And at the click of a button, they can advise the emergency department of the arrival time of that patient, and they can also send the patient's full details and a summary of the triage as well. So the staff within the emergency department are expecting the patient, but more importantly, they understand what the patient is attending about and their symptoms. And the last couple, we can also book a face-to-face or a telephone appointment in one of the 18 urgent treatment centres in the region. And those 18 urgent treatment centres have been absolutely critical over recent years with ensuring that footfall into our emergency departments is kept to an absolute minimum. We can also electronically refer to our own clinical assessment service for a telephone assessment from a GP or an advanced practitioner. And we can also refer to an out-of-hours GP electronically. And the last point, really, really important, we can also take a 111 call, and if a patient needs an ambulance, we can dispatch that ambulance almost as if the patient had rang 999 to begin with. That all happens seamlessly in the background, electronically. And in addition to that, we can also take a call for a patient anywhere in the country, and our health advisors complete the call, and details of that call will be automatically presented to the dispatch of the appropriate ambulance service, wherever that may be in the country. Again, all done in a matter of seconds electronically. So I'm just going to get into a little bit more detail, specifically about last year and the service that we provided. So this slide is really just to give everyone a little bit of a flavour of the breakdown of where we are signposting or booking patients in or advising them to attend out of all of the calls that we receive. And this is a fairly typical month. So for the purpose of this presentation, I looked at December just gone in 2021. And as you can see there, all of the percentages. I'll not go through all of those, but that gives you an idea of the breakdown of where patients are being asked to attend or signposted, or where they're being booked into. I just want to spend a little bit of time talking about that ambulance percentage rate of 17%. Whilst on the face of it, it may well seem quite high, and it is indeed, I would say it is high. The national average tends to be between 10 and 15%, so in that respect we are an outlier. But what I want to talk to you today about is what actually sits behind that 17%. So the actual percentage of patients that received an ambulance is far less than that 17% that is reported nationally to NHS England. The actual ambulances that are sent from those 111 calls in December last year was something like closer to 7%. So that's the output from Pathways data. However, a lower category ambulance outcome might have been reached. The call may have been reassessed by a clinician, and the clinician may well have downgraded that ambulance, so the patient in that scenario wouldn't have actually been sent an ambulance. They might have been asked to attend a nearby emergency department. What also might decrease that 17%, the patient may well decline the offer of an ambulance for whatever reason. Or in some cases, in our emergency operations centre, we may be in escalation. And what I mean by escalation is those critical periods of pressure within 999 where we really have to focus all of our resources on those patients that need our help the most. So in times like escalation, we prioritise our most unwell patients, and therefore less urgent ambulances may well be downgraded. And in those scenarios, we would ask the patient to attend a local emergency department themselves. So for all of those reasons, that 17% will reduce to the 7% I referenced there as well. It's important as well to mention as well, throughout all of those 100% of calls that are being managed, typically 1 in 5 of all of those outcomes will have been referred by a clinician within our 111 service. And I say 1 in 5, that's because, as I was talking about earlier about those complex calls, typically 1 in 5 of all 111 calls that come into our service, the health advisor will recognise that the call is too complex, the patient has a lot of presenting symptoms that are not easily triageable by NHS Pathways, and in those scenarios they will essentially early exit, is the term we use, and they'll transfer that call to a 111 clinician so that the clinician can speak to the patient and understand what level of care is best for the patient. And as I say, that typically happens in about 1 in 5 cases. So looking at the demand across 111 and 999 in 2021 as a whole year, these are some facts and figures in relation to our demand for the year. As you can see, they greatly exceed the targets set by NHS England. It's important to recognise that most of the 111 and 999 providers experienced very similar outcomes last year as well. We were no different. So I want to spend a few minutes talking about why our performance, our historically good performance, took a bit of a downturn last year. So you can see there that the first bullet point, our 111 service was offered in 2021 1.23 million calls, and we actually answered just over 700,000 of those, and we had an abandonment rate of just over a third. Our average speed of answer was almost 15 minutes. And on 999, we were offered just over 500,000 calls, and that's a 28% increase on the previous year. And of those 532,000, we answered just over 500,000. Average speed of answer on 999 was 31 seconds. And I'm pleased to say the abandonment rate wasn't quite as severe as 111. It was just over 4% there. So I want to spend a little bit of time talking about the reasons, particularly on 111 first of all, why our performance took a bit of a downward turn last year. And the first thing to mention is the change in call patterns. We saw in-hours increases to our 111 service. Historically, 111 has been an out-of-hours service. The original intention of 111 was primarily to be an out-of-hours service, with obviously calls being taken in hours, but not substantial call volumes being taken in hours. So last year we saw great increases as a result of patients being unable to contact their own GP. There were some days where there was up to 45% increase on those historically those 8 till 6 periods where a GP practice should be open. We were seeing almost a 50% increase. And personally, I think that was a little bit of a hangover from the early days of the pandemic. For a good few months when the pandemic and COVID first hit, the national message was ring 111. In a sense, all GP practices shut up shop. They didn't want to see patients, and all patients were directed to 111 to manage. And that message stuck. And during that period, NHS England also were running a campaign called NHS 111 First. It's important to recognise that actually that campaign was for patients to think about 111 First as an alternative to attending their local emergency department. However, I think that message got a little bit lost in translation, and I think the message over the 2-year period of the pandemic was ring 111 for everything. And 111 over that period become a little bit of a replacement for contacting a GP practice. So as I say, we were on we bore the brunt of much of those increases, with calls increasing during the historically quieter period of in-hours for 111. And we saw increases last year to calls to 999 as well. And because I talked about earlier about our dual train strategy that we have, that's served us very well for 10 years now at North East Ambulance Service, for the very fact that we operate a dual trained service across both 111 and 999. Because we saw an increase to our 999 service with calls, that meant obviously we had to protect our emergency service. So in a lot of cases last year, we had to divert all of our workforce to answering those calls on 999, because they were obviously emergency calls. And that essentially wasn't a headache that some of the other 111 providers in the country had, because they weren't operating a dual train system, and in some cases they didn't have a 999 service to run. I think it's really important to mention as well, health advisor absence increased to record levels. We've got a workforce in our emergency operations centre in call handling of about 350 health advisors. That's probably going to increase to about 500 in the next 6 months. And I'll come on to that in a moment. And obviously we weren't, as such a large workforce, we weren't immune to COVID. So it's really important to stress the fact that during last year, there were periods where up to 35% of our call handling workforce were absent themselves with COVID. Indeed, the management team, and I was part of this as well, the management team was decimated to 80% absent at one point. Our team leader team, of which there are about 25 team leaders all managing these 350 health advisors, the team leader were decimated to 50%. So throughout all of that, we continue to offer the 111 and the 999 service, but obviously as a result of the call handling workforce being reduced so substantially, that had a consequence, and that consequence was that calls took longer to answer. So I've mentioned one of the reasons why absence increased last year. But the other reason was increases with mental health absences as well within our own workforce. So we strongly suspect that an increase in mental health related absences is in part due to the fatigue of our staff having to battle through COVID over the last 2 years. That, coupled with the health advisors being on the receiving end of some challenging calls from the general public, some of which unfortunately have been abusive in times. That's all taken its toll on our staff. So we've had an increased absence rate with mental health reasons last year as well. The final point I want to mention as well, the handling time of our calls to our service has increased as well. Typically, 999 calls tend to average about 7 to 8 minutes, with 111 calls maybe between 8 and 10 minutes. both 999 and 111 calls have taken longer to get through over the last couple of years, and there's been a few reasons for that. There's been increased offline time to read the ever-changing announcements and pieces of news, and the fact that we've been responding to the ever-changing picture on a national basis, particularly in the early part, the first 6 months of COVID. It felt, I mean, I was working through this as well, obviously. It felt like we were coming in every day and there was a new piece of guidance coming out from NHS England on how we had to manage certain elements of COVID. That then meant that we had to disseminate that information to our health advisors, who then had to take time offline to read that information in order that they were given the correct information to the callers to 111 all of the time. And that's been throughout. That's still a relevant point today. And the final point, before I've talked a few reasons there about why we haven't been able to answer calls as quickly as we previously have. The final point, we've had with our health advisors increased time spent negotiating a service referral for patients. Now, this can be one of due to a number of reasons. It might be that the patient simply doesn't want to attend the GP practice, or they don't want to go to an emergency department or whichever, but all of that takes time in having that discussion and that negotiation with the patient. But in some cases as well, it might be that the health advisor, as I talked about before, when the services present on screen, it might be that the health advisor looks at a service, offers it, and tries to attempt to get an appointment within that service. And after they click the button to see if there's any appointments available in that service, the return might be that there are no appointments in that service. Now, the reason for that over the last couple of years, very similar to what I've just talked about. All of our services in the North East have all been experiencing similar pressures with their staffing and workforce as well. So it might be, in some situations, that they simply didn't have the clinical staff to be able to offer out appointments. Now, all this has an impact on the 111 and the 999 services as well, because again, that means for every service that the health advisor takes time to negotiate with the patient and then calls up to check if there's any appointments, then they find out that there isn't, and then they have to go through the same scenario with the next service that presents, and so on and so on. And all of that combined with the many thousands of calls that were taken each day will obviously have an impact. All the while this is happening, we've got new callers to 111, and they're sitting in a queue waiting for the call to be answered. It's really important to understand all of that background, and I hope that helps demonstrate and helps everyone understand why we haven't been able to answer calls as quickly as previous years when we've delivered the 111 service. Before I move off this point, this slide, it's also important to note we've done some research quite recently, and I'm not going to profess to know the answers to this, but I think it's an important point to share as well. Proportionately, calls to 111 by a percentage of the region's population is significantly higher in the North East when compared to our counterparts throughout the UK. We've looked at Yorkshire Ambulance Service, we've looked at North West Ambulance Service covering Manchester and further south, and the figures are quite clear. Essentially, we have double the amount of patients accessing 111 as a proportion of the population compared to most other areas in the country. Now, why that is, I don't know. I have a few ideas. It may well be that 111 is more established in the North East because we ran the pilot in Durham and Darlington for 3 years. Or it might be the fact that patients in the North East have more difficulty accessing primary care in the North East compared to other parts of the country. But as I said, I don't know the reasons why. That does need some more additional research. But I think it's really, it's another important point that actually we are twice as busy as some of our other 111 providers elsewhere in the country. So I'm just going to come to the end of the presentation, but I want to first of all, I'll end with touching on our demand this year. And I'm pleased to say we have turned a corner. You can see there's some figures year to date on 111 and 999. So from January the 1st on 111, this was correct as of a week or so ago, we've had offered 131,000 calls to 111. We've answered 82,000 of those. The abandonment rate has decreased, I'm pleased to say. It's now 29%. Average speed of answer has came down massively from that 30-odd minutes I was talking about earlier to just 11.5 minutes. Similar picture on 999 as well. We've been offered just under 20,000 calls. Again, important to know that's a 9% increase on that same period this time last year. And we've answered just over 19,000 of those calls. Average speed of answer on 999 is 15 seconds, with just a minimal 2% abandonment rate. So just going back to that 111 abandonment rate, I think it's really important to share the month-on-month decrease that we've seen since October last year. So at the worst point, and I'll say worst, at our most critical period in 111, probably when this correlated with when we had most staff off. October, we saw an abandonment rate in 111 of 60%. November, that decreased to 50%. December, that decreased to 42%. Last month, it decreased to 33%. And month to date, I'm pleased to say it's decreased to 19%. Now, that's still 19% too much. Obviously, that's not where we'd want to be. Ultimately, we want to get to 0%. And so that all the calls coming into 111 are answered within service level and nobody feels the need to hang up the call. In terms of call answer performance during January, just putting us on a national level with our counterparts, Nhs were 25th out of 35 111 providers in terms of their call answer performance. And this month, our average speed of answer on 111 has now reduced to just 6.5 minutes. Quite an improvement, I'm sure you'll agree, from the 38 minutes that we reported last October. So I hope that demonstrates to everybody that actually improvements are being made. It's all heading in the right direction, and we are absolutely taking this seriously. Before I take some questions, I've talked a little bit about the service improving. I just want to talk a little bit about how we've made that happen. The most critical element of why that's been able to happen is a large-scale recruitment campaign for, and I've kind of touched on this already, for an additional 152 health advisors for both our 111 and our 999 service. And that recruitment campaign, I'm pleased to say, is on target, and that's continuing for the rest of this year. If I can gloat a little bit, ours is on target, and from listening to colleagues on NHS England provider calls, it would seem the rest of the country is struggling a little bit. So we're getting something right in the North East with how we recruit staff. This month alone, we've welcomed another 53 brand new health advisors to our Emergency Operations Centre, and they're either out of training now and taking live calls, hence those call handling improvements that I've talked about, or some of them are still in training and will be live early part of next month. In addition to that, we're introducing a third contact centre in Teesside for additional health advisors. We've obviously outgrown, we can no longer fit all of these 500 staff in the 2 contact centres that we have at the moment. And that obviously means we're tapping into the job market in south of the region as well. And what else? We've recently worked with our Dental Commissioner and NHS England an improvement to almost double the number of appointments that we offer for patients with an urgent dental concern. And again, I highlight that point, that's a strategy that's unique to the North East. If you ring up 111 in any other part of the country and you have a dental complaint during the in-hours period, the likelihood is you'll just be asked and signposted to a local dentist. And the probable outcome of that will be that the dentist can't help you. In the North East, we're able to offer an urgent dental appointment electronically within one of the 17 dental hubs. In addition to that, I've recently taken on a project to understand and review average handling time with our health advisors to understand why it's increased and, more importantly, how it can be reduced safely over the coming months. And another one of my recent tasks is reviewing our patient survey results to understand what our patients are unhappy about and what we can do about it. And the Trust have also helped drive recruitment and improve attrition by introducing a refer a friend scheme for new health advisors, and that includes a cash incentive for the existing member of staff that's making that referral. And we're also planning a thank you gift offer to all North East Ambulance Service employees at the end of next month, just simply to recognise the hard work that they've been through over the last 2 years. We'll also be offering health advisors additional training, which will result in a nationally recognised qualification in customer service this year. We're also in the process of devising a talent management programme for our aspiring team leaders. And in addition to that, our occupational health department, the Trust is recruiting a staff psychological wellbeing officer. Goes back to the mental health concerns I was talking about with staff being absent. And we're also in the process of converting a number of meeting rooms in our emergency operations headquarters to quiet rooms for staff to unwind after particularly challenging calls. Probably talked about them out of order, but you get the gist. So I hope that's been useful to understand 111 and 999 in a little bit more detail about what the service is that North East Ambulance Service delivers and how we deliver it, and the pressures that we were up against last year, and more importantly how we've turned a corner this year and how our service is now on that path to improvement. If anybody has any questions, myself or my colleagues at Nhs are happy to take them.
Councillor Kay.
Thank you, Chair. Just so I've got this right in my head, referring to dental care, are you saying that if I ring up 111 in acute pain from a dental problem, that I will be signposted to one of the 17 hubs throughout the NEAS region, or is there another process has to be gone through before I'm actually presented to a dentist or somebody in that capacity?
That's it. I'll give you a yes and no answer. So this all depends on the triage and how urgent and severe your dental concern is. So within all triages, the outcome, let's stick with dental. The outcome will be typically that the patient needs to be seen by a dental provider within a particular time frame, and that time frame, depending on what's shared from the patient to the health advisor, may well be between 2 hours for those significant and very urgent dental concerns, all the way up to 3 days. So the dental hub strategy that I've talked about, those have been set up with those just under 500 appointments per week. Those have been set up to help manage and signpost those patients with particularly urgent dental concerns. So if your triage resulted in an outcome that you needed to be seen by a dental provider within 2 hours, within 6 hours, within 12 hours, or within 24 hours in some cases, then yes, you would be, without further ado, asked to attend one of these dental hubs in the region. And all of that information would be electronically transferred. There would be no need for you to contact the dentist. The health advisor within 111 would say your appointment is here and it's at such and such a time, and then off you go.
Just come back and just to say that I think that's a marvellous service that you provide, and one that I was unaware of, and I assume I'm making the supposition anyway that a lot of the general public are not aware of that. How are you trying to get the message out there that this is available, particularly since COVID? I haven't seen my dentist since pre-COVID, you know, and I think a lot of people are in the same position. This at least could be of help to them should they be unfortunate enough to find themselves having a dental emergency. So how do you promote it?
It's a great question, and I've worked with our dental commissioner quite closely for 3 years now, and we've attempted to promote this with NHS England. 3 years ago, a few months before the pandemic, we took ourselves off to London at a conference, and we tried to engage with a number of senior people within NHS England to say, look what we're doing in the North East. Dental access continues to be a problem. It was a problem 3 years ago, and it's even more of a problem now because of the pandemic, obviously. So yes, there are things happening at a national level. I'm part of a project at the moment to look at how we can take the next step and create a true electronic booking system with dental providers. Part of that project, I'm attending a couple of meetings in the next couple of weeks. That will be a long process. But to answer your question in the short term, 111 is about to launch a pilot service where at the very outset of the call to 111, and I'm not sure whether you're aware of this, but when a call is made to 111, the call is answered on a national basis by an automated message, and that's managed by NHS England. And after the system greeting, essentially, the call is then routed to the appropriate local 111 service, and that's where we pick it up. This pilot that I'm talking about is going to be with a number of service advisors who are going to be trained to triage dental calls nationally, so taking dental calls for all of 111. And they're then going to signpost the patients to these local dental hubs. In terms of local marketing, no, I don't think we have gone out and promoted that. And I would have some reluctance to do that, I have to say. And the reason I say that is those 466 appointments that we offer out every week, the utilisation of those appointments is round about 98–99% on a weekly basis. And I've already essentially been cap in hand to our dental commissioner last year to say, at that point we were offering about 250, and I said, look, because of what's happening in dental with the dental practices, we really need more of these appointments. And obviously I shared the data, and he was really receptive and enlarged the dental hub strategy, almost doubled it to those appointments that I talked about now. So there's a lot going on with dental at the moment. It's they typically make up between 10 and 15% of all 111 calls, and I think if you talk to anybody senior at NHS England, they will openly recognise the fact that it's largely been a forgotten element of 111. And I'm pleased to say Nhs has been almost at the forefront of what we're doing on a regional basis in driving some different ways of working, I suppose, is what I'm saying. I'm not sure if that answers your question a roundabout way, but no, we haven't promoted it, but it really does go down to the triage process. If your need is great enough, then you will get an appointment.
Yeah, I feel I've been educated a little this morning, so thank you for that.
Owen?
Thank you, Chair. And thank you very much for that presentation, very comprehensive presentation.
Okay.
I mean, I know that you understand that we're here just to provide scrutiny, if you like. That's what we call a scrutiny committee. And also we're here because of major concerns of people within our communities around the ambulance service, which is causing nervousness, if you like, and anxiety. And I just want to, not on the issue of dentistry, but Councillor Kerr's question, I think, was very apposite regarding how we actually can give some confidence to our communities about what is happening. So it is about communication. It is, I think, about us as well as councillors knowing our communities, communicating to our communities about what is happening. I applaud you actually, and all of the issues that have gone on over the past 2 years regarding more pressures because of COVID. I do that, I congratulate you. But I also understand, and I think we all do here, that it is often about capacity and what you're able to do. You can only do so much with the amount of funding you get, and you've already described a situation where you've gone out to say we need more. So I'm not in the business of criticising you for what actually is a government funding NHS issue, but I do feel that I have a responsibility to my residents that I represent. How can we, do you think, actually provide more confidence in the ambulance service itself? Because I know when I speak to them, they are anxious. I'm not just talking about older people either. I'm talking, about people who are vulnerable in all sorts of ways. So that's a very long-winded way of asking my question. But I did want to thank you as well, and also, make you understand that I know that some of these issues are not ones that you can address. Thank you.
Thank you. I think then it's probably important to note that prior to the pandemic, our 999 and 111 service delivered the services exceptionally well. 111, which has been probably my bread and butter for 12 years now at Nhs. Prior to the pandemic, 111 was continually in the top 6 of best performing 111 providers within the country. And as I've talked about today, that's obviously slipped a little in the last 2 years, but I think what I've talked about today, I hope helps everyone understand why that is, and why what we're doing now is going to help us get there again. So if you want to offer the residents of the communities that assurance, it's quite simply that. We've delivered an exceptional service to the patients of the North East for many, many years now, and that's slipped a little in the last couple of years. But as I've demonstrated today, we're on the road to recovery again, so that's the assurance I would say that you need to share.
Mark, can I just ask a question very quickly? On the dental service that you offer, are you looking to enhance that service so that if we can let our residents know, because to be quite frank with you, as Councillor Kay said, that it's not well known out there that people are scratching around to get a dentist when they've got really very bad problems, and they're not aware that they can ring 111. Obviously, if the suggestion was that you put, do a nice little notice to put in all the doctor's surgeries, you'd probably be overrun. Exactly. But it is really not known out there at all, and it was such a valid point that Councillor Kay brought up there. So I just wondered whether you're going to look to expand that. Yes, Mark.
Thank you. I thought perhaps I might come in there and help
Fine,
out
Mark,
if I can. Thank you. I think the question that is being asked is what is 111 for, and what is 111 actually doing? And the 111 service was commissioned as an urgent care service when the slogan that is used, and you often see it on the side of our vehicles, when it's not a 999 call, but it is still urgent. And that service is developed around assessing the clinical need of the caller and then matching that need to the services available within the time frame available. Now, obviously, the last 2 years have completely turned that model upside down and on its head. And I appreciate that this committee has just recently looked at accessibility into other services. And clearly 111 is a route into there, but it's not the route at the moment. And I think what's being asked here, if I understand, correct me if I'm wrong, is a suggestion to promote 111 as an alternative route into other services where it's not currently set up to do that. And the concern would be twofold. One is that 111 is not an advice line. It is a higher acuity urgent care line. And if you were to promote it for other services, it becomes a lower acuity line. And alongside of that, it then increases demand. As Mark has already mentioned around dental care, for example, he's allocating 98-99% of all of the available dental slots without any promotion already taking place. If we were to advertise 111 as being an opportunity to get dental appointments, it would be overwhelmed. But worse still, you'll see some of the abandonment rates and that call average handling time begin to increase again, because there wouldn't be enough call handlers to answer the volume of calls that would be coming in. So I think the question being asked is, what's it there to deliver, and what would others like to see it doing? That's a wider question, which is a very good one to ask, but perhaps it's not one for us as a provider. It's one for a wider discussion around how do we want to model our health services for the future.
Thank you for that, Mark. And from my experience, because I've been to the dentist twice through the pandemic, and they're only doing half the appointments because of the clean down, and so that has really made things terribly difficult for the dental service. It's quite a process now when you go to the dentist. So, yeah, I do get what you're saying. Thank you. Thank you. Any more? Oh yes, Ken.
Thank you, Chair. Hi, Mark. Thank you very much for that talk this morning. It's been very interesting. You would appear to be offering a very comprehensive service. There's an awful lot of stuff in there I didn't know about, particularly the dental stuff. But could I just ask, I mean, do you very often get calls on psychiatric matters? Yeah?
Yeah.
Insofar as I didn't mention it, that's all, you know, and there doesn't seem to be a specific number for people to call in that vein.
We do. We get a significant proportion of our calls to 111 with those patients having a mental health episode. It's something we've set up a couple of years ago. We've got good links in with the two main crisis teams in the region, and essentially, not to go into too much detail about it, we essentially offer a warm transfer process. So if the outcome of the triage that the health advisor conducts recommends that the patient needs to be seen by a mental health professional or a crisis team, then the health advisor can make a phone call to the local, there's two of them operating in the north and the south of the region. They can make a phone call and refer that patient, and whoever answers the phone will take the details and call that patient back. It's quite seamless. And I think other 111 providers offer similar. They may, in some scenarios in the country, they've made their telephony, they've constructed the telephony in such a way that it's an offshoot of any mental health related calls right at the beginning of the call. But we've taken a decision not to do that. And we take all patients through a triage because in some cases the patient may well not need crisis team involvement, and it might be that they just need to talk to an in-house clinician, for example. But yeah, to answer your question, yes, there's a significant proportion of calls that relate to mental health, and those are managed well within the service.
Let Rochelle ask a question and then Shirley.
Thank you. First of all, I would just like to say thank you, because it seems that it's very competent, and it also looks like independently you are being very proactive in trying to make things better. And I didn't also know about any of the dentistry stuff, and I totally understand that if you don't have the capacity, you're not going to advertise it because it's going to affect figures in different ways. But my question's also around time. So a couple of weeks ago, I thought I had I didn't know I had appendicitis at the time, but I'd rang 111, and on the phone call, obviously at the end, when you're talking about, they'll direct you to either your GP or hospital or accident and emergency. Now, for instance, on this specific case, I'm going to talk about myself, but I presume that it applies to a bigger picture, is if I'm told by 111 that I need to be seen within 6 hours, does that time frame take into account that the person sat in A&E waiting? Because I understand that my, not diagnosis, but my situation was very time precious, and I sat in A&E for 18 hours. And I've heard that it's not just me personally, but speaking to residents in my ward, that time spent in A&E, I know that that's not your responsibility. However, I do think that might need to be taken into account when you're sending people and you're giving them a time frame, because a lot of people are saying that I didn't think that I'd be sat in A&E, and they were getting themselves quite worked up because they were thinking I need to be seen within a certain time frame. So I just wondered whether that was something that would be maybe taken into account, or if it was already.
Yeah, we've battled this for years, and the terminology within Pathways has changed a couple of times over the years. It's a bit of a misconception, and I'm not sure whether the health advisor inadvertently said the wrong thing, but most dispositions will be phrased in such a way that you need contact with the service within that particular time frame. So in the scenario you're talking about, the very fact that you've actually made contact with a clinical environment which is then deemed safe, then that essentially is the box ticked. You've met that recommendation from Pathways. Obviously, you know, we recognise that other services are under pressure as well. So when you're attending that service, you may well, unfortunately, have to wait. And that does sound very unfortunate. The urgent treatment centres, the 18 that I mentioned in the presentation, the appointment booking system that we've got with all of those 18 works really, really well. I think where there's probably work to be done is that work around emergency departments. And NHS England have tried to help with that with, and I touched on this at the beginning, they've tried to help with that with the arrival times. So that electronic handoff process from 111 to the emergency department has helped with that. But I have to say, anecdotally, I've heard that even with that, the patient will arrive within that arrival time. And then because of general footfall from patients that haven't spoken to 111, that then obviously increases pressure within the emergency department, and then it has a knock-on effect. And what the original outcome from the triage with the 111 health advisor was for the patient to attend within 1 hour. So they attend within 1 hour, but then because of other factors coming into the mix, they're sat there waiting, as it sounds like you have as well. So it is unfortunate, yeah.
And then finally, I really appreciate you coming and giving this presentation today, and I'd wondered if it might be prudent in the future, maybe in 6 months' time, to maybe come back and give us an update on things like, I know you mentioned that you're proactively going to go and have meetings about the dentistry care, maybe maximising capacity.
Yeah.
Is there any chance that we could maybe work into the programme that they come back and give us an update?
Well, we'll have a look at it.
Yes, if you'll have me again, I'll happily come back. Not a problem.
Thank you.
Thank you, Mark. Right, now we've got Shirley.
Thank you, Chair, and thank you, Mark, for the presentation. A couple of things. First of all, about the power of Facebook. I do know about the dentist service and the 111. I've seen it a couple of times when people have obviously raised the question, and there's been advice given by other members of Facebook have said to ring 111. So I was aware of that. My other question is to you is, what about the waiting times for drop-offs at hospital? Has that improved? Because quite some months ago, I was quite alarmed at how many ambulances were queuing up outside of Darlington Hospital, for example, waiting to drop patients off. And there was just such a backlog of people waiting in the hospital, waiting to be discharged and go home in ambulances. And they couldn't obviously go home because they were still waiting for the ambulances to be emptied coming in. So has that situation improved? Because I really was quite alarmed when I did see that for myself. Thank you.
I'll defer to Paul if that's okay. Thank you, Paul.
Thanks, Mark. Just to pick on the point of handover delays, I think Mark's mentioned in his presentation, I think every single NHS agency's been under pressure in similar ways, whether that's been increased demand or whether that's been a shortfall of workforce. So we have had increased difficulties over the last couple of years, brought about by the pandemic also, where there's a lot of infection control prevention measures have to be put in place. So it's not just as easy as taking a patient into ED and offloading them. There are certain protection that we've got to give to patients to ensure that infection isn't passed between other patients in there. So there's been some issues common that that Mark's mentioned today. I think what we will see is that actually handover delays are improving. They're improving across the board, and that's ultimately been brought about by the fact that workforce is getting back to normal, and indeed demand fluctuations are decreasing. So we are seeing a bit of a relief around that, but that's notwithstanding that we are working with a lot of trusts around how we work together to try and improve that even further going forward. And a lot of that is about, we play a part in that around trying to deal with patients more in the community rather than taking them into ED departments, coming with creating new pathways of care so that we can actually avoid going to ED and deliver patients to other alternative destinations. So I think there's a lot of work going on, but I think we've got to recognise that we've got to work together in a partnership way to try and improve that. But we have seen improvements more recently with handover delays across the board regionally.
Thank you so much. And just another little thing as well, about with my COVID champion hat on, I do believe that the hygiene has got to continue. I know restrictions are reduced now, but I do think that people's responsibility, services that are provided, you mentioned about the reduced service within the dentist there. I do think that hygiene has got to be one of the paramount things that we all continue to do. Every member of the public, every service that's provided, because during the early lockdown stages, it was proved, wasn't it? We heard all sorts of tales, of queues in men's toilets and all sorts, to wash your hands. That hygiene element has got to continue. I just needed to put that in there. Thank you.
Thank you, Shirley. Lucy? Thank you, Chair. Thank you, Mark, for the presentation. I think what you've demonstrated this morning is just how much progress has been made since the last time I sat in a health committee talking about ambulances. It clearly demonstrates there's a lot of work being done, and I thank you for that. I'd also like to take the thanks back to the staff who have been delivering all the services for us. It has been extremely difficult for all staff. But more so on the front line, and I think there's a message to go back there. I'm pleased that you saying the thank you of the gift back to, because often it's easy to complain, but it's harder sometimes to say thank you, and I want to do that this morning and ask you to take that word back.
Thank you.
Anybody else want to speak on this? No? Can I say thank you? Thank you very much for that. It really was very comprehensive. And I think we've got a good idea of the problems that you've got and obviously the problems that the pandemic has caused, which is, the only word is havoc, really, isn't it?
Absolutely.
So I think that now you're in recovery, yes, next time we'll probably get some good news.
Yes, indeed.
Yeah, I mean, thank you so much for coming.
Thank you.
Thank you. Right. Can I ask the committee to note the report and the presentation, please? You want to come in?
Yeah. Chair, just before members agree that recommendation, there was call for a further update to come back to committee, so I would suggest that that's incorporated within that recommendation. And also, there was a request made prior to the meeting, but not in time to be accommodated within the meeting, that whether Nhs could do some kind of a heat map or an analysis of the pattern of service requests within County Durham, and if that might be able to be done, how that might be presented back to committee. So I know that that Nhs are considering that request, but again, that might feature as an additional supplement to that recommendation too, Chair.
We haven't discussed that. Mark, yes.
Thank you, Chair. Yes, I'm aware of that request that Stephen mentioned came through to us. Our data analysts and informatics people are looking at that at the moment. Apologies, we weren't able to bring that to you here today, but half-term commitment for some of that team got in the way. So I will have an update for Stephen probably in a couple of weeks' time, and if we've got some information to share, I thought if I pass on to Stephen, he could then circulate that report to the rest of the committee.
Thank you very much, Mark. Okay. Do we agree? Agreed. I haven't been informed of any other business, so can I say thank you very much for attending. Please can I remind members to stay muted until IT has been confirmed. Okay, thank you everybody.